again. You explain ADHD as a dysregulation disorder. What does that mean?
But I really struggle with the word disorder, but I really spent quite a lot of time umming and ahhing about whether I have the word disorder in the name, because there is a very powerful movement and drive to not use terms that have a pathological connotation. Yet, coming from my perspective, working as a doctor, working as a psychiatrist, I'll get back to the name bit in a minute. I'm just taking you on a little detour first. But as a psychiatrist, I really see it when this collection of traits becomes disordered. It becomes problematic. And having looked at all the evidence that's available around ADHD, particularly in adults, the outcomes are really negative. This is a really impairing and damaging condition if not recognized and if not managed well. And without a doubt, it is, in this context, it's a disorder. So I decided to keep the name disorder, but with a caveat that I recognize that there is also a very legitimate social construct of ADH. I'm going to say ADHD, but don't forget the D means disorder, so you're a bit stuck. But anyway, that's the little.
I just to interject here, I struggle with that too. One of the big struggles I've been going through right now as I'm working on a new book is the sort of disorder superpowers dialectic.
Yep.
Which I know is sensitive in the community, but I have to say also, and I'm doing a survey actually right now, and it's fascinating, of business professionals who have neurodevelopmental issues or mental illness. And I asked them, has your tricky brain caused you problems at work? 100% say yes. Do you think you have special skills because of it? Almost 100% say yes.
Yep.
Does that resonate with your sort of experience?
Yeah, I think if anyone is going to go as far as to get, it's really difficult to get assessed and diagnosed for ADHD these days because of waiting lists and struggling to get through lots of barriers and so on. And if someone's been through the process of assessment and they have met criteria, then by definition, they are impaired, because one of the criteria of making a diagnosis is not just having this collection of features, which we can talk about in a bit, but it's also having a sufficient threshold of problems, of functional problems in one's life. And so it's a different thing to say, I've got a few ADHD type traits, but it hasn't met diagnostic threshold. Once it meets diagnostic threshold, it's by definition causing significant impairment in multiple domains. And so I have a sort of fluid relationship with the concept of ADHD, and maybe it will be encompassed in a more broad neurodiversity category down the line where there's domains of different aspects, because there's so much overlap here. You know yourself. There's so
I think it is. I totally think there's this beautiful, I call them tricky brains, neurodistinct, neurospicy. I really think there is this movement that we are different for good and ill.
Yeah.
But we're not typical. And I might get in trouble with for saying this, but like, we're not like other people often. We're just not.
Sure, I agree, and it's an amazing. I love working in my job, and it's so interesting. And I suppose I've been grappling with this issue ever since I really understood ADHD, and it was quite late on in my own personal and professional journey. I didn't really appreciate that ADHD, in most cases, continued into adulthood or continued to cause problems into adulthood in the majority of people. So I didn't really have it on my radar when I was starting out as a psychiatrist, as an adult psychiatrist. And
really,
yeah, we were a little bit behind America, I think. So, and I've been a psychiatrist for quite a few years now. The reality is that I managed to get a few years into training before really understanding that it was a common thing in adults. And that understanding and breakthrough actually came through my own journey of realizing that I had ADHD, and having my own assessment and having this light bulb moment, which was just a remarkable experience, and one that I talk about at the beginning of my book and the introduction section, right at the start of the book. That sort of almost like this realization, this uncovering of this thing that's been there the whole time, but it just wasn't. It just didn't. I didn't have a framework for it.
I
I
know.
remember thinking through. So I've clearly got something that's not right, and I was going through my detailed checklist of anxiety disorders and depressive disorders and personality disorders. Although I hate the concept, and trauma related stuff. And I sort of I put it down. I pinned it on trauma reaction because my mother had a very bad accident when I was 6 years old, and I thought that's it. And then suddenly, one day, unexpectedly, I was reading an article written by Professor Philip Asherson, who's probably one of the leading researchers in adult ADHD in the world, a UK guy. He's my colleague now and friend, but I read an article that described adult ADHD in some detail, and it was like, oh my goodness, that's what it is. How could I miss that? And suddenly I then go into hyper-focus mode and learn as much as I possibly can about ADHD. And then I realized that half my tricky patients as an adult psychiatrist had this thing probably. I needed to go back and reassess lots of people. And indeed, where I suspected it, it often was present, and recognizing it and treating it in all sorts of different ways. Was making a huge impact in that individual's life. Because often if you don't recognize the ADHD, you get an ever-growing build-up of other problems, other mental health problems, substance use problems, work problems, family relationship problems, and other addictions and so on.
I actually, you interviewed on a podcast. I'm blanking on his name, but I think you interviewed one of your patients who
Yeah,
hosts.
Matt Willis. He's a pop star, like from a boy band that in past
Which
days.
boy band was he in?
Busted, if you've heard of Busted, it was very big in the UK and I think internationally as well. So they split up, but they come together again. But he's also a really good actor and happened to be my patient, and he's obviously given full consent for me to. I went on this podcast and he was open about it, so we
It
can
was,
talk
I,
freely.
yeah. I mean, I really recommend listeners you go check this out because, and first of all, because he talks about how he was in marriage counseling with his wife, and that the sort of ADHD aha, as my friend Laura Keyes would say, was part of the counseling experience. And he was resistant to it at first. He was like, no. This is about our marriage. This is about us. And I think he also used substances. But then the ADHD aha was such an opening. And it's very funny because those of us who are married to people with ADHD will recognize never pay bills on time, don't mail things, can't find stuff, leave a mess, explode in anger for no reason. All these sort of things. I mean, I've been married a long time to someone with ADHD, so I'm kind of used to it, but they really affect our well-being and the people around us.
Yeah. No, listen, I think his story is not unique. I think that many people, by the time they reach adulthood and haven't been diagnosed, let's assume they've had this thing and they've been compensating in some ways, healthy ways, and other unhealthy ways. And compensating for many years is really quite draining, and having this mask or what you present to the world. And often in the 30s and 40s, things start to break down in some area. And this is like most people with ADHD will recognize this concept of feeling like, you're juggling balls and there's a fine balance and anything could go wrong and it could all fall apart. And that's, I think, what many people with ADHD feel, because again, we can talk about it later maybe, but the autonomic nervous system in ADHD.
Let's talk about it now. Yeah.
Yeah. I mean, the autonomic nerve, there's evidence coming out that the autonomic nervous system is quite dysfunctional. So the autonomic nervous system is this beautiful balancing act, as is everything in the body actually, between two opposing forces, two systems, the sympathetic nervous system and the parasympathetic nervous system. So the stress response, the fight or flight, adrenaline response on one side, and then the rest and recovery, rest and repair, rest and digest, calming, relaxation response on the other side. And this system's in a very fine balance at all times. Well, it hopefully is in a fine balance. Now, when it's not in a fine balance, people are in a perpetual stress mode. They're almost on high alert, hypervigilance, scanning the environment. Back to that sort of am I in danger moment. Now, that's quite common, we all experience, but there's a cluster of problems with the autonomic nervous system, many different types of problems, actually poorly understood and poorly recognized and poorly treated certainly in our health system, which is under the umbrella of dysautonomia, disorder of the autonomic nervous system. The best known of those is POTS, or postural orthostatic tachycardia syndrome. But other people will have vasovagal things. They'll have Raynaud's, where their fingertips and toes change color, and temperature regulation issues, and sluggish gut, and all sorts.
My son went through one where they thought he had POTS, where he would pass out and then have what looked like a grand mal seizure.
Sure.
And it took us so long to figure out what the heck is going on. And I actually think that he had sort of a neurodiversity meltdown. It was after a big event. It was after a lot of stress.
So I really think that when we start to think about ADHD from its physical health comorbidities, the sorts of physical health problems that cluster together with ADHD, that actually we're only just really starting to understand, because we haven't really been focusing there. We've just been focusing mainly on the brain. And actually, this is the problem. This is a real problem, because if you just look in one area, then you will find the pathology and the problems in that area. But the moment you flip the camera and look at the physical body, and I'm talking about the sorts of physical health problems that cluster together with ADHD at higher levels than you'd expect, you find some very interesting things.
What, like what?
You find, it falls into various clusters, but a couple of the really interesting ones. So you find people with dysautonomia, disordered autonomic nervous systems, higher levels of POTS, and these various other issues. You find higher rates of immune type problems, so more allergies, more autoimmunity, and higher rates of conditions that are suspected, that I believe have quite a strong immune basis, like chronic fatigue syndrome and fibromyalgia and chronic pain disorders and so on. So there's lots of this immune overreactivity, allergies plus, and also high rates of autoimmunity as well. That's where the immune system starts making mistakes and starts sort of attacking the self. So you've got these clusters going on there. You've got high rates of migraine, and you've got high rates of diabetes. And interestingly, you have very high rates of hypermobility. So this is lax connective tissue, lax joint laxity, the people who can bend their body into all sorts of different positions and party tricks and extra flexible, and often did gymnastics in childhood. And it's all great until it's not great when you have hypermobility. And the reality is, so 10 to 20% of the general population are hypermobile. In ADHD, shockingly, and this was really where my entry point into this area, because I started recognizing that a lot of my patients had connective tissue issues, had hypermobility. I was getting like 35-40% of my patients. Oh my God. And then the study came out not so long ago, a couple of years ago, that showed approximately 50%, half of all people with ADHD are hypermobile. Now, when you dig down into this a little bit, I mean, that's a big number. I mean, when you see something so strongly associated in that way, you really do start to question whether it's part of, that they're connected, they're like the same thing. And that's what I'm starting to believe to be the case. So
sorry, I have a cat who is making.
Welcome the cat.
Dog. Come on.
So this is really important, this next bit. Being hypermobile per se is not necessarily pathological or problematic. People can bend their body in strange ways and they're fine, they're perfectly fine. However, a lot of them are not. Us are not. I have hypermobility issues. And there is a very characteristic cluster of problems that clusters around people with hypermobility. and they overlap very strongly with the cluster of problems around ADHD. In fact, ADHD is far more likely in people with hypermobility. It's the other way around is true as well. So what I'm trying to say is I think we're looking at a multi-system problem in some people. I don't think everyone with ADHD fits into this cluster, but I think there are many that do. But we struggle to think about it in these terms because the evidence that we have, the studies we've done, the evidence that we've got to date does indicate it's a very brain-based thing. But I think it's because we've not been really looking in other areas. And so I think there's a very strong immune basis to ADHD. I think there's lots of evidence to support that, the inflammatory hypothesis of ADHD, as I call it. And when we start having a bit more of a paradigm shift and shifting our focus to a step back, all of medicine has got very, very, very subspecialized and very focused in on the minutiae, the particular system you work in. What we've lost, I think, is that broader perspective that basically shows that there's a network of problems that are all interacting. And when you start to notice that and see these body-based things are really common, and they're associated with inflammation, and they're also associated, when we're talking about dysautonomia, with inconsistent blood perfusion or blood flow to certain places in the body, including the brain. Why do you think you get dizzy and lightheaded when you stand up with dysautonomia? Why do you think the heart races really fast? It's in order to try and maintain the blood supply and oxygen supply to the brain. So you get these symptoms as a sort of form of compensation. The question gets really interesting when you say, okay, so that's obvious. When someone stands up and they feel faint and they maybe faint or they get symptoms, this is obvious. What if someone has a bit of dysautonomia, chronic, low-level dysautonomia? What would that look like? Well, we know what that looks like. It looks like brain fog. Now, then you get into what's the difference between chronic brain fog and difficulties with memory and energy expenditure and all of these things.
Perimenopause.
From that versus ADHD, when it's chronic and continuous. It meets the criteria. They look similar, very similar. Yeah. And because there's so much overlap, you start to question, are they the same thing? That's what I've been doing, is thinking about, is this one big picture we're looking at? And you might have not seen it yet. Behind me, you'll see the model. I'll try and see if I can zoom the camera. Let's see if I can do this.
The somatic super syndrome.
Yeah,
and it's that I lost it after that. Why don't you read what it says?
Well, let's have a look.
Just the title.
See if you can.
And it's neuropsychiatric signature, the somatic super syndrome and its neuropsychiatric signature.
Yeah. So on my screen, it looks the wrong way around.
Yeah, we won't be able to see it, but if you want to share it, we can.
Sure. But the point is that on the side where all the arrows are coming out, there are all a load of neuropsychiatric features, things that we know: anxiety, depression, sleep problems, cognitive problems, sensory problems, fatigue and pain. And the point here is that all of the things on the other side of the screen that are feeding into it are all physical health syndromes, dysautonomia and mast cell activation, hypermobility. The point is these physical things are driving the mental health neurodevelopmental symptoms. This is nothing to do, but it's obviously to do with the brain because inflammation goes to the brain.
Hold on, so are you saying that it's it's not the ADHD driving the dysautonomia, it could be the dysautonomia driving the ADHD?
That's exactly what I'm saying, and that's really quite something, isn't it? Because,
wow.
People, I've been looking at this for a long time now, and
hold on, you're out of frame a little bit. There you go.
I'm coming back to you. I've been looking at this a long time now, and the reason why I started looking at it, well, one of the reasons was because my daughter, at the beginning of COVID, I'm talking about the immune aspects of ADHD now. At the beginning of COVID, my daughter developed something that turned out to be a brain autoimmune problem. She's okay, she's fine, and she's given me permission to speak about it because it's so important. It's called PANDAS, if you've heard of it, PANDAS. Yeah. And it's an autoimmune problem that basically, in response to an infection, streptococcal infection, the the body makes a mistake and starts attacking a part of the brain called the basal ganglia in the middle of the brain. In fact, an area that's relevant in ADHD and in Parkinson's and so on. Anyway, it gets attacked. And, when this happens, it often comes on suddenly, overnight. My daughter suddenly developed a whole cluster of very dramatic symptoms, including a worsening of her pre-existing ADHD and sudden onset obsessive compulsive disorder, like the severity of which you would not believe. Anyway, I realized it wasn't how I thought mental health problems present. It was so dramatic and so acute, and she was having some twitches and stuff, so I knew something else was going on. But to cut a long story short, it was extremely traumatic. And we once identified it, we treat it with, not with like ADHD medication, with anti-inflammatories and antihistamines and antibiotics as well, because of their anti-inflammatory function. But what I saw was this condition which looks like a mental health presentation, severe OCD, but has an inflammatory basis. And as we got a handle on the inflammation and dialed the inflammation down, the OCD and the ADHD and the anxiety dialed down correspondingly. And when she got another flare of her PANDAS and the inflammation went up and we started to work out what causes the flare, all of those symptoms ramped up like a volume going up and down. So over the last 4 years, I've been watching mental health symptoms driven by inflammation going up and down, directly linked to the inflammation. And I'm like, this is definitely not just my daughter. And how many other people have in part an inflammatory explanation to their mental health symptoms? And I've become very interested in this. And it links with the hypermobility story. It's the same group that get it. And this, you can look at my family, and I've had various issues, and my other daughter's extremely hypermobile, and it goes back throughout the whole family network. And this was all invisible to me, and all the doctors that I've come across don't necessarily recognize this cluster. And it's a very big cluster, and it's driving a lot of mental health symptoms. And we have to learn about it. It's really important. So that's where my interest has been, in the somatic or physical health overlap with ADHD.
So can I ask? Oh, no, sorry.
I was just going to cycle back to your original question, which is about the name. But you asked the thing we wanted to
Yeah,
ask.
I just want to ask one more question on this sort of neurobiology, and then we can move on, because I want to talk about work a little bit.
Of course.
And you've said something like, our traditional way of looking at ADHD as sort of a dopaminergic seeking situation, or a neuroadrenaline seeking situation, is far too narrow.
Yeah.
What is your interpretation of, my brain needs more stimulation, needs to fire more dopamine receptors, and that's part of it?
There's no doubt that the treatments which directly increase available dopamine and noradrenaline across the brain, that they work. There's no doubt about it. In fact, they're so effective. These medications really, how effective a medication is referred to as its effect size. And the effect size of stimulant medication, for all the criticism they get and all the misinformation out there about them, they're really effective and generally well-tolerated medications. And they really do improve things. Interestingly, one of their side effects is a slight increase in blood pressure. And interestingly, they are, in fact, in America more than here, a treatment for POTS. So we could actually be seeing some of the benefits of stimulants through their blood pressure enhancing effects, treating the dysautonomia, which actually is in part the ADHD. So that's a separate thing. But what they also do is they increase dopamine and noradrenaline in the brain. So clearly increasing those neurotransmitters improves things. And until relatively recently, we have reverse engineered this finding to say, okay, well, ADHD must be a problem with the dopamine or noradrenaline receptors or transporters in the brain. And so we've been having all these hypotheses and having all these what we call candidate genes, which are expected genes that are going to be abnormal. Now, in parallel, there's been this sort of study of the genome-wide association studies, where they're basically with bigger and bigger groups of people with whatever disorder you're looking at their genetics and looking for certain genes that stand out as being variants in these groups. And certain genes are coming out, and virtually none of them are to do with neurotransmitter receptors or transporters. They are finding lots of brain-based abnormalities, things to do with neuronal development or synaptic development. So they're finding a few genes around that. And then that's where the story ends from an ADHD perspective. Oh, look, we found these genes, and look, they have brain-based functions. Now, what I did a while ago, and again recently actually, is through using AI, I said, okay, I'd like to know the other functions of those genes, because genes have various different functions, not just one. And lo and behold, those genes that came up as being important in ADHD that have the scattering of neurological effects also have immune modulating effects. Many of them do. They have connective tissue effects. So there's effects across the whole body. And that's suddenly really interesting. So this is perhaps not just a brain thing, although we have lots of data to show that it is a brain thing, but it's like looking at an elephant and being so honed in on the elephant's trunk that you think, isn't that amazing? This problem, this is, this in animals is amazing. It's got long, it's all this. And then you don't realize that the trunk is attached to the rest of the body. And you have to zoom out and you go, oh, look, there's legs as well. And there's a tail. And isn't it interesting? It's like walking into a shopping centre through one entrance, through the car park, and going, oh, this is a pretty grim shopping centre. Okay, it's a bit poorly lit. And then realising that you could have come in multiple different entrances and seen very different things and described in your analysis of the shopping centre just a very narrow perspective of a very big thing. That's how I think it is. So I do think the brain's involved. Of course the brain's involved. But I think the body's involved in many, many cases as well.
I mean, I think in a way, this sort of goes back to the sort of paucity of attention and research on adult ADHD, because the framework of, certainly in America, of ADHD that has been around forever is, I have a hyperactive boy, he's impulsive, he can't pay attention, blah, blah, blah. He is a risk taker. So of course I'm going to give him this medication that's going to sort of feed his brain in a way that calms down that impulsivity and that risk taking and all the things that drives teachers crazy.
Yeah.
And boom, that's the explanation. Like, that's what I grew up with. I think that's the dominant. And of course, I would imagine studying adults with ADHD, it can look so many different ways from that, not to mention gender, right?
Sure. So, yeah, absolutely. So ADHD usually comes hand in hand with at least one other mental health or neurodevelopmental problem. Like 70 to 80% of people with ADHD have at least one other mental health. But it also comes with this whole network of other physical health problems often. And depending on what other stuff you have coming along with the ADHD. So if you have autism together with ADHD, it looks different. If you have an anxiety disorder, if you have a trauma in your childhood and you have post-traumatic stress disorder, which happens more commonly in ADHD for all sorts of interesting reasons, then it's going to shape the way your ADHD presents. If you use substances, if you have really poor nutrition, again linked to the ADHD, that's going to add other layers of complexity. So yeah, so let's get back to your initial. This is such an ADHD moment. You asked me a question, and we've gone off on this great tangent, and I'm going to bring it right back now.
Listen, I could tell you when I sit on Zoom with people, I can instantly tell.
Yeah, no, it's definitely a
energy.
radar there, isn't there? It's so funny. So this is back to your original question, that I refer to ADHD as I refer to it as either disorder or an issue with, depending on what mood I'm in, with regulation, or shortened to a dysregulation disorder. And the reason why I do that is because I realized, having had this all my life and studied it for the last 20 years and worked with hundreds of people with it, I realized that every single feature of ADHD can be explained through a model of dysregulation.
Define
And
dysregulation for the audience.
yeah, so it's where
My
when a
audience knows
system.
it, but it's always good to define it.
So you remember I told you that these two opposing forces are pushing against each other in the autonomic nervous system. Yeah. So if that system is regulated, there's going to be a nice balancing act here. You know, one's not pushing too hard, and the other one's not too weak. It's a nice balance here. When a system is dysregulated, it's either too much, too strong, too hot, too or not enough.
Yeah.
Yeah. So it's as if you're shooting or archery at a board, and instead of hitting the bullseye every time, you're going off. You're just dysregulated. Sometimes you're hitting the bullseye, but you're going off in quite a haphazard angle and just overshooting things. So this makes complete sense from the science around ADHD, by the way, because you would have heard of the concept of executive function, that the functions of the frontal part of the brain, the frontal lobe, that are like the conductor of the brain, that regulate the brain. And the main way that this part of the brain does that is through the ability to put brakes on, to inhibit. Okay, so you can think of the frontal as toning down the rest of the brain, so that you don't react in a knee-jerk, impulsive, reactive way, that you're able to sit and stay with things. And that if you need to do a project that has multiple steps in it down the line, then you're able to see that process through, prioritize and hold things in mind and move through a series of stages, not get distracted here and there and everywhere, and get to your target. Now, in ADHD, there is a problem with the regulator, with the inhibition. You have something called disinhibition. And that lack of brakes or inhibition basically means that all other functions of the brain and body become dysregulated because there's no brakes. You move too quickly or too slowly. And I realize that we understand this concept presently from quite a narrow lens. We think about the three main domains of symptoms. One is attention, the other is impulsivity, and the other is hyperactivity, or more broadly, activity. Okay, we think about hyperactivity, but actually, so those are three domains. We also think about, although it's not part of the criteria, but it's accepted as a core symptom of ADHD, the emotional dysregulation. So we've got four domains. Those are my first four domains of a model that I've created called the 10 domains of dysregulation. One is attention. So I'll come back to it. 2 is activity. 3 is impulse control. And 4 is emotion. Now that's only 4. Just to give you a flavor of this, why is this relevant? Because think about it. Most people with ADHD or critics of ADHD say, how can this person have ADHD? They're sitting and gaming for 6 hours. They hyper-focus on this project better than I've seen anyone do it. In a workspace, this is particularly relevant. And it's like, it's not possible. And attention deficit. What do you mean attention deficit? This person's got unbelievable attention. No, they haven't. They've got dysregulated attention that can both be in a deficit state where you can't sustain attention, you can't latch attention. The problem there is actually latching on. Or when you're latched on, you can't pull away. It's a dysregulated relationship with attention, as is the same with impulse control and activity. Some people are hyperactive, but other people are really have apathy and can't get motivated and are bored and are just stuck. And there's definitely not too much activity. And the emotional dysregulation of ADHD is like a whole topic of its own right, but very heavily influenced by rejection sensitivity, which is a very important concept.
I want to flag that and come back to that later.
Yeah. And so just that's introducing the concept. Now you'll notice that my model is the 10 domains of
Yeah, what are the other
dysregulation.
6?
Exactly. So the other 6 are basically a product of all of this area that I've been looking at and talking to you about until now on the podcast, which is this broader perspective. So one of them is on sleep. We know that the circadian rhythm or the sleep cycle in ADHD is biologically dysregulated. Another one is time appraisal, which is definitely dysregulated in ADHD.
Please, that triggers me. No one in my house has ever been on time, ever.
There's the immune system. is dysregulated. I told you before, immune overreactivity, making mistakes and attacking the self, producing too many chemicals that lead to too much pain or too much fatigue. The arousal and energy expenditure is dysregulated. Arousal, both brain arousal, but also the autonomic nervous system. This is all about, where do we channel energy? Do we need to channel energy to the muscles and the heart so we can run away from this dangerous situation? Or is it safe? Are we in parasympathetic mode where we can regulate, you can put more blood to the brain? How are we regulating the autonomic nervous system? That's the domain. So yeah, and there are more, but that's the idea, is that multiple domains in ADHD. My book deals with it in detail, and if people will resonate with this, because there's no doubt about it, because it's just a far more nuanced and complex and in-depth analysis of something which we have just been focusing too much on a certain crime. And we've actually been focusing in a narrow way, partly because that we're used to dealing with it as a childhood problem. And it's everything about ADHD in the way it's described is very child-centric. Even the criteria to diagnose it refer to, running around too much and but this model allows us to look in more depth, and actually allows us to describe ADHD in a much more realistic and accurate way, because people forget that the way that you diagnose something, the criteria for diagnosis, are not the same as the best description of that thing. They're there because they help differentiate between other things. You might have wondered why this name of this podcast, the Anxious Achiever, why anxiety is not on that list. I don't know, a person with ADHD that doesn't get anxiety, it's not on the list because it's not a good differentiator. It doesn't mean that it's not part of ADHD. ADHD and anxiety are like intertwined.
They're like peanut butter and jelly.
Yeah, and if it gets too much anxiety, it sort of becomes a separate entity in its own right, and you get a separate diagnosis. But ADHD on its own, without a doubt, and virtually everyone is riddled with anxiety, social anxiety, or phobic anxiety, or trauma anxiety. And so
virtually everyone who has ADHD, or just virtually everyone?
Virtually everyone who has ADHD struggles with anxiety.
I want to just check, Dr. Kustow. I called you Dr. Custard. I can stay on. I don't know if you have.
I'm fine. I'm happy to stay on.
Okay. And Mary, if you have to go at the top of the hour, I can just stay on and finish up. You are? Okay, cool. Awesome. Mary has ADHD. I hope you don't mind.
I bet you, Mary, that you can relate to some of these things. I don't know. Yeah, me too. I never imagined it was connected to anything else, but it is. Every single one of my medical issues over my lifetime, pretty much every single one, and this stands for virtually all of the patients I've assessed with this cluster, all of them can be explained through the hypermobility connective tissue abnormality. Because collagen, which is the thing that's abnormal in connective tissue, its functional structure is abnormal. It's not just ligaments and tendons around joints that it's in all of the tissues of the body, including the eyes and the wrapped around blood vessels, which tightens up to push blood there or push blood there, around the gut to move the stool, move the contents of the gut, that peristalsis, that's collagen fibers getting tight and moving. And it's also, not only do you get problems with hypermobility by damaging joints, by bending them too much or dislocating them because they're lax, but you get these whole host of other problems just because the collagen acts differently in all these tissues, meaning that you get this characteristic cluster of physical health problems, and they're all predictable.
Can I ask you a question?
Yeah.
Does chronic tight muscle tension, hypertonic muscles go along with this?
So interesting, very interesting. So people think of hypermobility. People think of hypermobility. So let's go back, because I want to just cut out that little bit. People think about hypermobility as being, your hands and your arms and maybe, your legs can bend into strange positions and do things. Some people don't have any of that. In fact, the diagnostic test or the test for hypermobility, the Baton score, is measuring whether you can touch your thumb down to here, whether that finger there goes up more than 90 degrees, and you can see mine doesn't, whether my elbow angles downwards at more than 10 degrees. It's various tests, whether I touch my hands flat on the floor. This is to test. The problem is, hypermobility can present very differently in different people. So some people have that characteristic thing, but a lot don't. My hypermobility is axial, down the center of my body. So what it affects is my jaw, grinding, clenching, wearing down my teeth, jaw pain, going up to temple pain, neck pain, and this at the upper back, it's called the coat hanger distribution of tension. Now, why? Because the muscles are tightening to try to protect the joint. Which joint in this case? The neck. Because if your neck can move too much, then it's prone to damage. And a lot of things travel down through the neck to the body. So it's very important that that's... So many people with axial hypermobility complain of completely the opposite. They can, like me, stiffness. My whole body's stiff the whole time. I can't... And
I have Botox. I mean, this is the biggest problem of my life
yeah,
right now, is that my entire coat hanger and jaw
yeah,
is locked so tight and so painful.
yeah.
You're
And you
blowing
might
my
have had lower
mind.
back problems in the past as well, potentially. I don't know, or not.
Mm,
Not so much. And so you sometimes get things with hips. You often get
all the time. And
flat
sciatica.
feet, hypermobility's flat feet, ankles that often twist and turn. So look, there's so much to talk about hypermobility. The point is that this is a really neglected and misunderstood area, and it is the root and source of so much physical and mental health pathology. Yet our medical system, by virtue of the fact that it has become subspecialized and that everything up here is dealt with by psychiatry or neurology, and everything down there is everyone else, and we're like so split. It's so wrong and so inappropriate. So we have to start thinking in terms of syndromes or systems. And when you start thinking like that, everything looks very different. And that your focus and targets of treatment broaden from just working on stuff that influences brain chemistry. It also, you start working on things that optimize blood supply to the brain or reduce inflammation or, etc. I think you got the message.
I'm just going to take a personal moment and say that this is really amazing, and I'm going to call my psychiatrist right away. I have bipolar disorder. I don't have ADHD. I act like someone with ADHD. Functionally, I am someone with ADHD, but I've never been diagnosed with ADHD.
Yeah.
But I have a lot of the symptoms. Not my executive function is excellent, and my all that stuff. So,
but don't forget that hypermobility syndromes. And what I mean by that, there's two separate groups. One is called Ehlers-Danlos syndrome.
Yes, I've been asked by body workers, do I have it?
Yeah, so that's important. The fact that they're asking you and they know about the body, that's important. So, but by far there's 13 different types of Ehlers-Danlos syndrome, but you can essentially, for the vast majority of people with Ehlers-Danlos syndrome, have hypermobile Ehlers-Danlos syndrome. It's the most common form. And that there's quite a high threshold to get that diagnosis. There has to be multi-system problems at a certain level. Now, there's another group that is still very pathological. It's called hypermobility spectrum disorder, but in certain areas it doesn't reach the threshold of Ehlers-Danlos, but it still can cause major problems. That's what I have, HSD, hypermobility spectrum disorder. And you will see that people with either of these things have very characteristic problems in very characteristic systems of the body. And the autonomic nervous system is one of them. The immune system is another one. The gastrointestinal system is another one, again, because of the sluggish movement through, but also to do with the fact that if there's immune overreactivity, the cells that are scanning for danger, the cells that are lining all the environmental interfaces of our body, the most important one of them is called the mast cell. It's a form of blood cell. And the mast cell is basically the first responder to any threat from outside. That's why they line all these environmental interfaces, the skin, eyes, ears, nose, gastrointestinal tract, genitourinary tract, and lungs. Everywhere the world meets the body. And these cells in this group are trigger happy, they're jumpy. They are like this scanning the environment for danger, the immune system scanning the environment for danger, and they have a real startle response. So they release chemicals, inflammatory chemicals, before they should. So therefore, those chemicals cause swelling. What are the chemicals? Well, the most well-known one of them is histamine, but there's a whole load more. And when you release histamine into tissue, what happens? It gets red and swollen. Okay, and you can imagine with the effect of a swollen lung tissue, you get asthma. A swollen gut, you get, especially if it's not moving properly, you get stagnation and you get imbalances, dysbiosis, and you get overgrowth of negative bacteria, and then you get damage to the lining and you get toxicity going in and the whole thing spirals. You also get a lot more outpouchings. There's more pressure in the system because it's not moving properly. And the tissue of the gut, for example, is fragile because its collagen is lax. So you get more hemorrhoids, more diverticular, more hernias, more everything. And so when you start to understand the sort of mechanism of all this, you can see how swelling, combination of swelling and impaired movement through systems can lead to all of these very characteristic problems with the gut, with the genitourinary system,
Yep.
and with asthma and the lungs. And down the line, when a system's getting stressed and the immune system's overreacting, you often develop autoimmunity as a later consequence. And it gets difficult. We need to try and catch these things early and try and intervene early.
So that's what I want to ask. I do want to just talk a little bit about anxiety and rejection sensitivity, but I want to round this out by saying, if, like me, you're like, oh my God, I need to talk to a doctor about all of this. We can read your book. We can fly to London and consult with you. What kind of doctor who do we go see?
No,
Who do
this
we
is
talk
a
to
challenge.
about this?
This is a challenge. So this is a multi-system presentation. In fact, my diagram there, do you see it was called the somatic super syndrome? What that means is it's a cluster of different syndromes. Dysautonomia, Little-Lacker syndrome, mast cell activation syndrome, Ehlers-Danlos syndrome, this sort of syndrome of gut problems that I talked about, the autoimmune type. So obviously, if you have a issue with whatever system of your body you have an issue with, you're going to try and seek out a doctor to deal with that problem. Now, that doesn't necessarily take a broad perspective. There are, in every speciality that's relevant here, a tiny minority of specialists who get this picture, who understand it, who've seen it, who've been working with it, who are treating it. Usually, those specialists are stigmatized by their colleagues because they're into this really weird thing that no one has much evidence about and it's so new. But what you don't realize is that our understanding is changing, and it normally takes about 20 years from new insights that emerge to be accepted in the mainstream. I think in this area, we're like halfway through that process. So there's a few clinicians, clusters that know it and get it and are standing up and saying that, but the mainstream has not got this yet. In fact, it's so interesting. Not only have they not got it, and I don't mean to, I'm seeing this from an understanding, like a compassionate point of view. They haven't clicked, they haven't realized this. And the problem is that we're a bit paranoid as a profession. And when we don't understand something, we weren't taught it at medical school, or we weren't, it doesn't fit into our current paradigm. We're a little bit quick to say, there's nothing wrong with you.
Right.
It's all in your mind. And I've got nothing to offer you. And all of the conditions that I'm talking about, whether it's ADHD, anxiety, hypermobility, dysautonomia, mold toxicity, which by the way is an enormous, enormous problem, mold toxicity. It drives this immune dysfunction heavily. But again, another big topic. Chronic fatigue syndrome, fibromyalgia, all of these chronic inflammatory things which fit into this cluster are currently stigmatized against in an unacceptable way. And I find it really very upsetting, There's millions upon millions of people with this cluster who are being told that there's nothing wrong with you. I mean, how can there not be anything wrong with
Oh,
you?
trust me, I've written about this. Spent 15 years. So what do we Is there something we can
So,
Google? I mean,
yeah, so I
how do
think
we?
really, I think if you fit into the hypermobility group and you've got multiple physical health problems and mental health problems, so I think the best resource online is to go to the EDS Society. On YouTube, there's hundreds of videos from all the specialists in all of these areas who get it. And through watching videos that you might choose to, if your issues are more immune based or fatigue based or gastrointestinal based, and you think that you want to look on the EDS Society YouTube channel for world specialists in these different areas, watch their lectures and start learning and start building your understanding. And then when you do go to a doctor for your problem, if you think it's part of this network of problems, you look for a doctor who understands the network. And there are, in my network, there are rheumatologists, autonomic nervous system specialists, they're usually cardiologists, gastrointestinal specialists, genitourinary, like urological specialists. Skin is a big one for the immune stuff. So there's a network of people, small numbers in each, that collaborate, refer to each other, and deal with this almost invisibly. And when they talk about it a lot, they're often stigmatized, a bit like the conditions. But I'm not scared of that, and I feel there needs to be a change. And I put my views into a poem. I think I read you when we first chatted, and you probably didn't know what I was talking about, why I was reading you a poem about mast cells
Now,
and
now I
toxicity.
do.
So I mean, maybe it's something your viewers might be interested in, because my goodness, was this a channeling moment for me? Honestly, it's like I felt that I was almost possessed, and I'm not a poet. I'm not someone who writes poetry usually, but I had to get some of these frustrations and messages out there in some form, and it just came out in the form of a poem that I called Systemic Toxicity, and it just deals with all of this that I've been talking about.
I'll post it in my when this airs. I'll post it in my
Sure,
newsletter.
sure, absolutely.
Okay, I want to just focus here and get just looking at my questions here.
I think what you were going to think about
I want
was,
to talk about anxiety and rejections. Okay, so okay.
and also
So,
maybe the positive aspects of ADHD that have been studied that are relevant to the workplace
sure,
might be interesting for you. I don't
sure.
know. I was just sort of guessing what you might ask me about, and I'm less interested in the whole reasonable adjustments question. I mean, it's an interesting question, but I'm quite interested in why do we want to make these adjustments to people with ADHD, but also mental health. Why do we want to help them help them function in the workplace? It's because there's a lot to bring. There's so much to bring there. There's so
I don't feel like
many.
I need to answer that question. My audience, they know the answer. They are these people, so I'm cool. I think that's
Yeah,
good.
good.
But I want to just dial into the anxiety piece. You have said I've not met a person with ADHD who doesn't experience anxiety, but obviously, so many of us have anxiety who don't have ADHD, right? You have to differentiate.
Of course.
Can you talk about some of the ways that you see anxiety presenting in people who have ADHD, who may not know they have ADHD? So a listener who has a lot of anxiety might be like, maybe the root of this is not what I think it is.
Sure. So I'd say probably the largest group is generalized anxiety disorder, which means anxiety, on a pretty continuous basis about lots of different things and not honing in on any particular theme. Um, I think it's important just to actually showcase the different types of anxiety, and then I'll hone in on a couple that are important. Another common form of anxiety is trauma in all its manifestations. That could be a classic PTSD type trauma or a CPTSD, complex PTSD, early trauma stuff. And there's lots of overlap actually with ADHD, but very prominent themes of anxiety running through that and getting triggered by something that causes an upsurge of anxiety. A really big one is social anxiety. When someone feels like they've got eyes on them, they have to present or speak up in a meeting, and there's a lot of anxiety inside that's inhibiting them. Dry mouth and sweaty palms and can't think and heart racing and can they tell and all of that stuff. So a lot of that sort of public speaking, stroke, social anxiety.
I hear this a lot, just anecdotally for listeners, with leaders who have ADHD who came up in a time where they were told they were stupid, or they were bad at school, or they had to sit in the corner. Of course you have social anxiety.
Sure. And so another big group that's often not talked about in adults, and I think is one of my real major interests these days, is sensory processing issues. So people with ADHD and autism, ADHD group's been relatively neglected, apart from in children where it's recognised, but we've forgotten, we haven't started thinking about it in adults yet, but I am, and it's very much informing the book. But sensory and sensory processing sensitivity or sensory processing issues, being either overreactive or underreactive to sensory inputs. The 5 senses that we know of, but also the other senses: proprioception, vestibular sense, and interoception. Again, big discussion, but there are 8, not 5 senses. And people who have sensory processing issues either experience things as too much or too loud or too bright, or are under responsive. And being over or under responsive, or having something called sensory craving, it leads you to interact with your environment in very different ways. And the risk is, for this group, is getting very overwhelmed by intrusive sensory inputs. And what happens when you get overwhelmed? Well, you shut down, or you get very dysregulated. Yeah, it's that same thing. That window of tolerance of dysregulation. When you go above it, you get all wired and angry and upset and ragey and very expressive of it. When you go below, you shut down, you dissociate, you cut off, you withdraw. And often people use substances to manage the upper pole and also to manage the lower pole, to stimulate a system that's understimulated or dissociated, or to subdue and calm a system that's overreactive. So in a work situation, people with sensory processing issues are going to be quite anxious because they're just the noisy office, the shared workspace, the flashing fluorescent lights, the
Fluorescent lights.
I
Oh
know.
my
And why
God,
do you
the
think many
fluorescent
people
lights.
with ADHD and this group of sensory processing issues don't like working in office environments? They like working in calmer, quiet environments usually. But anyway, so that's a driver of lots of anxiety. And the other biggest theme, which I think we're probably heading in this direction, is rejection sensitivity, which is a fascinating area and an area that needs study. I mean, there's no studies on it. There's no studies on rejection sensitive dysphoria. So I'll just give you an overview of it, or are you aware of it?
Well, I am, but I want my audience to hear about it. I actually want yes, please.
So for a little while now, there's been this concept of people with ADHD and possibly autism, again, we don't quite know, having heightened sensitivity to rejection. And a US-based psychiatrist by the name of William Dodson reconfigured a name and basically coined the term rejection-sensitive dysphoria, which he applies to the ADHD population. And the description of it is that for as long as you can remember, you have experienced a heightened, extremely heightened reaction to actual or perceived criticism, rejection, or being slighted or left out or teased or bullied or sidelined or whatever. And in response to that thing, your reaction is disproportionate, is dysregulated. Okay. And it is like a punch in the gut, a punch in the face. It's like incapacitated again. And sometimes it manifests with loads of anxiety, overwhelming, crippling anxiety, anxiety so you can't even think straight, that you feel like I can't even speak to anyone, often in anger towards the self or the other, sometimes in the form of rage. And other times it will cause you to be sad, withdrawn, upset, cut off. I'm such an idiot. I messed up again. They all hate me. And it might just be in response to what is a neutral comment, but is that sensitivity is perceived as a hostile comment. Now you can imagine in a workspace where everyone's getting feedback and getting, scored and compared and all this stuff. It's like a playground for rejection sensitivity. And many people with ADHD describe this trait. We haven't studied it. It's not been studied yet, and it needs to be before we can actually say anything substantial about it or with conviction. But anecdotally, after many years of practice and many years of living in my own shoes with this thing, I really relate to this concept, and I have done throughout the whole of my life. And it was so impairing at so many points until I understood it. And I was able to say to myself, you've just been triggered. Your RSD's just been triggered, and have a series of things that I do either in response or in advance to reduce the impact of it.
Tell us.
Well, I think this, before I tell you that, I was going to say one thing, that the overlap with trauma and being triggered by something and activating a traumatic charge, there's obviously an overlap here. So William Dodson believes that this is a physiological, biological thing to do with the regulatory systems of the brain. It's a symptom of ADHD directly. Whereas others argue that people with ADHD who have ADHD parents and siblings and who have more chaotic homes and lots more substance use, they are going to have more risk-taking, more impulsivity, are going to have more accidents, more traumas, more abuse, more falling off the edge of a thing. And therefore, trauma and ADHD are integrally linked. So it's really common to see people with ADHD who have various forms of trauma. And you can see how if someone activates your trauma by saying something that reminds you of it, it can look very much like this. So we have to be careful what it is. But if it is this non-trauma driven sensitivity, then I think there's three categories. The first category, I think, is you want to reduce the overall charge in the system. So what I mean by that is if you do have identifiable traumas in your history that play out in the present and cause you problems on a day-to-day basis, then you should do something about them, because there are very, very effective treatments for trauma now that can take that charge down, sometimes eliminate it, sometimes just reduce it. And they are really effective. Many of them involve body, actually, eye movements, tapping, shaking, various forms of body stimulation whilst engaging the material of the trauma. And for various reasons, it repatterns it and takes the charge away. And they're really, really very effective approaches. EFT, tapping, particularly effective. Very, very good. So you want to reduce the overall charge in the system. And then there's two other approaches. One is a preventative, proactive, before the event thing. And the other is once triggered.
Yeah.
The once triggered one, the key message there is, by an understanding of how it triggers you and what it looks like and so on, recognize it early, intervene early. That's the key message. And then use a variety of different things that work well for you to regulate and bring yourself down. For me, it's changing my environment, going like time out, going outside, fresh air, different, cold hitting the face, and tapping. I do tapping and I love it, and it grounds me very quickly. And if I get in there early enough, then I can definitely navigate away from an RSD event, because when you get triggered, very often you are incapacitated for hours, sometimes days. It really is quite profound. This is not just, I'm just a bit upset. It's really strong. And so you really want to try and avoid that and try and, get out there before you can. And if you do get triggered, you've got to try and bring yourself down, and that's important. The other one, which I think is much better, is actually doing a practice, and it could be different things. I can tell you what it is for me on a daily basis that keeps your system, your neurological system, your sensory system, your anything that you've collected along the way, keeps it tuned up, clears stuff as it comes up. And what I do, I developed my own protocol, and I used to use it just for myself, but so many people asked to be taught it, and that I first manualized it, and over the last year and a half I've created like a video of it so that people can, if they want to, download it and follow along with me, and like proper professional video and music and instruction how to do. What I've basically done is my interest in the body and emotional regulation and trauma and ADHD, which is all about emotional. I basically have been learning and studying all of these different approaches to process trauma, manage emotions, body-based things, cognitive things, physiological things, and I've just taken the most potent elements of about 14 or 15 different established approaches, pulled them into a 20-minute movement meditation designed to be done every morning with music that just brings in eye movements, tapping, breath work, inversion, power of gratitude and intention, and repetitive stimulation and acupressure point stimulation, and all of these different modalities into one place. And it's so powerful. And it's called Solo Soma. And I'm really proud of it. It's like it even started before the book started, and it carried on past the book. The book got published in October. It's called How to Thrive with Adult ADHD. But Solo Soma was something started maybe 8 to 10 years ago, and it's just emerged and developed into something I'm really, really excited about, because it works and it keeps you tuned up and keeps you, I suppose, unburdened by these charges. And when you're unburdened by charges and you're cleaning your system regularly, daily, through mindfulness and meditation and all this stuff, then, you know, the overall load in the system is significantly reduced. Therefore, you can weather a little bit of this or a little bit of that. You're much more resilient. And so you've got to think about it from a reactive point of view and from a proactive point of view. And I think your audience might be interested to access Solo Soma if they want. So if you're happy, I'll put a link in the details.
Please. I can't, I think we're going to end it now because I realize that I have a meeting, but I can't thank you enough for your work and your energy and your passion. And I feel it's such a gift for me to be the vessel to bring this hopefully to a new audience. So we'll link to it all. I can't recommend your book enough. And thank you.
Thank you very much. So nice to chat.